Eating disorders are a group of chronic psychiatric illnesses that are related to food consumption and are associated with a significant impact on the physical and mental health and social functioning of a person. There are 6 identified feeding eating disorders in the DSM-5-TR. These include pica, which is eating dirt, chalk, ice, or other types of what we would consider not edible foods, rumination, avoidance restrictive food intake disorder, also known as ARFID, anorexia nervosa, bulimia nervosa, binge eating disorder, and there are other specified feeding or eating disorders. ARFID is one of the newest additions to the DSM-5-TR. Eating disorders have a high rate of psychiatric comorbidity. Keep in mind that psychiatric disorders often travel together. There is a high rate of mortality among these psychiatric illnesses, not from suicide, but from the physical problems that result from the feeding and eating disorders themselves. Anorexia and bulimia are more common in females and typically begin in adolescence or young adulthood. The peak age of onset for anorexia is 15 to 19 years of age, and the peak onset of bulimia is between 16 and 20 years of age. A higher number of males are diagnosed with ARFID and with binge eating disorder, with a mean age of onset at about 25 years. Historically, screening and assessment for eating disorders was focused on young, thin, cisgender white females. However, eating disorders are prevalent across all sexual orientations, gender identifications, racial and ethnic groups, and as primary care providers, we need to be aware of that. Comorbid disorders are common across the spectrum of eating disorders. People that have anorexia, bulimia, and binge eating disorders often are diagnosed with anxiety, mood disorders, and substance abuse disorders. And those with ARFID are most likely to be diagnosed with anxiety disorders. Eating disorders are associated with high rates of self-harm. A third of individuals report non-suicidal self-injury, especially among those who have more body dissatisfaction. 43% of those with anorexia, bulimia, or binge eating disorder have suicidal ideation. Non-fatal suicide attempts are seen across the diagnostic spectrum, most often in those diagnosed with anorexia nervosa, binge purge, and bulimia nervosa. Death by suicide is found in about 1 in 5 who die because of anorexia. Death by suicide is higher in those with bulimia and binge eating disorders than in the general population. Recovery from feeding and eating disorders entails the resolution of the disorder, normalizing the eating patterns, improving health outcomes such as weight gain or stopping weight loss, and improved body image. A little note about pica. You may know somebody who eats clay dirt. Some pica is culturally accepted and is not considered pica. Primary care is a good setting to screen for eating and feeding disorders because we have access to growth charts and the people's history. Suspect an eating disorder in anyone who presents with rapid weight loss or failure to gain weight or difficulty gaining weight, or has a body image disturbance and obsessive food practices, or thoughts about weight or shape. Also, suspect it when you see growth stunting or pubertal delay in children and adolescents. That may be a sign of an eating-feeding disorder. A note here, kids that take stimulants for ADHD often have problems gaining weight, and that's not an eating disorder. Hiding in the pantry to eat chips may be indicative of an eating disorder. Screening tools include the SCOFF, the Eating Disorder Screen for Primary Care, Eating Attitudes Test, and the others that are listed here. This is an example of the SCOFF questionnaire for anorexia and bulimia. SCOFF stands for Sick, Control, 1, Fat, and Food. And you'll notice here on this that they talk about 1 stone. That's a British term. 1 stone's equal to 14 pounds in our English or American scale. A no to every question means they're unlikely to have an eating disorder. For every yes, they get 1 point, and a score of 2 is a likely diagnosis of either anorexia or bulimia. If they answer yes to one question, it may be useful to look at their eating patterns and whether there are any body image issues present. There is a little line below the asterisk next to the SCOFF questions that is a link to the SCOFF article and tool. Assessment of a person with suspected eating and feeding disorders starts with getting a really good history. Include the past medical history. Any family history of eating disorders or other psychiatric illnesses is important. Get a social history. Are there any recent stressors or traumatic experiences, such as bullying, physical or sexual abuse? Are there any substance abuse or change in mood or behaviors? Get a 24-hour dietary recall and a nutrition history. Are there any changes in eating habits or weight gain or loss? How long have those been going on? Any changes in exercise patterns? Get a menstrual history, the age of menarche for females. Conduct a really good review of systems, the signs and symptoms of malnutrition, dizziness, cold intolerance, menstrual irregularities, fainting. The physical exam should be complete, including checking height, weight, BMI, and growth charts to ensure that the child's growing appropriately. Each organ system can be affected. Get vital signs and look at each of the systems. Then you can get some labs, a CBC, electrolytes, liver, thyroid, celiac panels, and a glucose. Also, get a urinalysis and a drug screen, and get an EKG. The physical signs and symptoms of eating disorders affect every system. Dermatological, there's dry skin, hair loss, brittle nails and hair. There may be knuckle abrasions from making somebody vomit, peripheral edema from malnutrition. Cardiovascular, you may see bradycardia, hypotension, orthostatic hypotension. Some arrhythmias and sudden death from prolonged QT can occur. GI, constipation, diarrhea, bloating, and esophagitis from persistent vomiting. Neuro signs include syncope, some brain atrophy, fatigue, and vertigo. Musculoskeletal, you may see signs of osteopenia, osteoporosis, and there may be fractures. Endocrine issues include hypoglycemia, low sex hormones, and amenorrhea. And fluid and electrolytes, you may have elevated BUN from muscle breakdown, low potassium, magnesium, sodium, phosphorus, and bicarb. Each of these presenting signs are going to be determined by the length of time the person has been having the eating disorder. The more rapid the weight loss, maybe the more critical some of these are going to be. These are the DSM-5-TR diagnostic criteria. Anorexia nervosa, there are 3 key features for diagnosis. 1, energy or food restriction leads to low body weight for the age, gender, and growth trajectory. May be minimally normal for a child or adolescent. 2, profound fear of gaining weight or fatness with patterns that prevent weight gain. 3, body image disturbances, significant self-evaluation is tied to weight or shape. They can't recognize the seriousness of the low weight. Anorexia nervosa is further characterized into restricting or binge eating and purging. Adults, the severity is classified by BMI. In children and adolescents, it's by BMI percentile, or the percentage of the median body weight as determined by the BMI. Children are growing and weight gain is expected as they grow because of muscles and bones. So you can look at the way that a child or an adolescent is growing, and if they're not meeting their BMI, what percentage are they away from that BMI? I think that's what they're trying to say here. Bulimia nervosa is recurrent binge episodes, either using vomiting, laxatives, inappropriate thyroid medication, or excessive exercise. The criteria here are 1, eating more than what most people would eat in the same time period, and 2, loss of control or feeling that eating cannot be stopped. For binge eating disorder, the criteria are eating more rapidly than normal, eating more until uncomfortably full, eating large amounts of food when they're not hungry, eating alone out of shame, this is like hiding in the closet, feelings of disgust, guilt, or depression after eating. Diagnostic criteria for ARFID. Avoidant restrictive food intake disorder is characterized by a persistent inability to meet dietary needs for nutrient demands or growth. They may be disinterested in food or have a sensory experience such as fear of vomiting or choking. It may begin after an adverse experience. Weight loss, childhood weight gain is below expected, or there's poor growth. There's nutritional deficiency. There's a reliance on alternative feeding regimens such as enteral feedings or supplements. There's significant hindrance in psychosocial functioning. This is not due to food insecurity, cultural practices, or other medical or mental disorders. It's not related to body image disturbance. This is more than being a picky eater. Often it overlaps with autism spectrum disorders. Other specified feeding or eating disorders are eating disturbances that cause significant impairment in health or psychosocial functioning, but they don't meet the criteria for the other diagnoses. That would be atypical anorexia, subthreshold bulimia or binge eating, purging disorder, or night eating syndrome. Differentials for these eating and feeding disorders include any primary medical conditions that may be underlying, that may affect the heart, the gut, the musculoskeletal system, or their ability to eat. Psychiatric illnesses such as anxiety, OCD, body image disorders, schizophrenia, and borderline personality have to be considered. The management for eating disorders occurs across the healthcare spectrum and can involve ambulatory outpatient care to inpatient care. A multidisciplinary team is needed to deal with medical and psychosocial issues. Intensive outpatient therapy involves attendance in group or individual therapies, and meal supervision, nutritional therapy, and family therapy. Typically, adolescents can attend after school hours. Then each is a step up in intensity: partial hospitalization, residential care, and inpatient care is reserved for those at the high risk of suicidality and uncontrolled behaviors such as purging. Pharmacologically, medications are commonly used with psychotherapy to treat associated disorders such as depression and anxiety. Olanzapine, a second-generation atypical antipsychotic, has been used to promote weight gain. Nothing has been approved yet by the FDA for the treatment of ARFID. Non-pharm treatments include cognitive behavioral therapy as the first-line treatment for most eating disorders. Families often need counseling as well. They struggle with control issues, how to control the child's behavior, which makes them sick as well. There are some complementary therapies such as mindfulness, yoga, and meditation. Education for eating disorders is necessary so that people understand the disease or the disorder, the progression, and the treatment plan. The DSM-5-TR description and classification of sleep-wake disorders has expanded to reflect overlapping medical conditions that affect normal sleep. Common problems seen in primary care include insomnia, obstructive sleep apnea, restless leg syndrome, and substance medication-induced disorder. The classifications under insomnia disorder include difficulty falling asleep, difficulty staying asleep, waking up too early, and are often comorbid with depression, sleep apnea, and reflux. I can't sleep may not be the chief complaint. You may notice the person looks tired or is dozing off in the chair, or they're not attentive. Insomnia has consequences. Remember that disorder means that life has become disorderly, unmanageable, or difficult. I think of 3 actors and musicians who died trying to sleep: Michael Jackson, Prince, and Heath Ledger. They used sleeping pills and other drugs to combat depression and insomnia. It's estimated that 40% of adults report difficulty with sleep. 17% report it as a serious problem, and 6 to 10% meet the criteria for insomnia. Females are slightly more affected than males, perhaps owing to hormonal cycles. Insomnia is more common among middle-aged and older adults. Sleep cycles can be disrupted by physical problems such as pain, arthritis, environmental like noisy neighbors, light, temperature, jet lag, and shift work. The primary care provider, the FNP, has to ask specifically, "Tell me how you're sleeping. Does the pain wake you up? What shifts do you work? How do you get yourself ready to go to sleep? What is your caffeine intake? Do you take drugs? Do you drink alcohol? Do you snore, or does your partner say you snore? Do you take daily naps?" It's important to remember that we spend 1/3 of our lives sleeping. Sleep is restorative and has hemostatic rewards for us. It's critical for normal thermoregulation and energy conservation. We have to rest in order to be able to do things. Sleep deprivation for prolonged periods of time can lead to hallucinations, ego disorganization, and delusions. Get a good history. Especially do a review of the medication list if it's available to you. You can look at it and see things like, "I see you take Seroquel. What do you take that for? How long have you taken it?" Ask about movements during sleep. Ask about snoring. The history will help you develop a list of differentials and start to rule out things such as restless legs or sleep apnea. A daytime sleepiness scale can also be helpful. The differentials should include medical causes such as pain, fibromyalgia, delirium or dementia, GERD, ulcers, shortness of breath, obesity, pregnancy and postpartum, and nocturia. Psychiatric causes or contributors to insomnia include major depressive disorder, generalized anxiety disorder, manic episode, psychotic illnesses, trauma, PTSD with hyperarousal, poor sleep hygiene, and other sleep-wake disorders. A sleep study can be used to assess for sleep apnea, periodic limb movements, or REM sleep behavior disorder. The DSM-5-TR criteria for insomnia disorder include these. It's the kind of the rule of threes. 3 nights per week for 3 months. Then it has to cause significant distress or impairment in functioning. That's daily living. Common symptoms are the difficulty falling asleep or staying asleep or waking too early, fatigue or daytime sleepiness, a preoccupation with sleep, distress because of the inability to sleep, decreased energy and mood disturbances. Insomnia can be a chronic, lifelong illness which needs long-term treatment. Non-pharmacological treatment includes cognitive-based therapy as a first-line treatment. Then sleep hygiene, about the learning about how to go to sleep, what to do in order to get ready for sleep. Also, mindfulness and relaxation can be helpful. Pharmacological treatment, you got to consider the risk-benefit ratio. Benzodiazepines can be used for short periods of time. Remember, they're category 4 controlled substances. Melatonin receptor agonists such as Ramelton, which is Rosarum, can be used. You also have benzodiazepine receptor agonists, or the Z drugs, such as Lunesta, Sonata, and Ambien. These are also category 4 controlled substances. Sometimes antihistamines such as Benadryl are enough to help someone get sleepy enough to go to sleep. But for our elderly folks, make sure you check the Beers criteria before prescribing any of these drugs to a geriatric patient. This is a list of the things that are included in education for sleep hygiene. The main rule is that a person maintains a regular sleep-wake schedule 7 days a week, whether they're working or they're not working or on holiday or at home, that they eat regular meals, develop a relaxing bedtime routine. They do the same thing every night, limiting liquids and caffeine before bed, avoiding daytime naps, getting regular exercise, making sure to reduce bright lights in the evening, and that includes the TV and the computer or the cell phone. Making sure that the bed is for sleeping, not for reading or for working. Turn clocks away from the bed, and if you're not asleep in 20 minutes, get up. It is helpful to ask the person to keep a sleep journal for a while so that you can look at patterns and review them with that person. Restless leg syndrome is a difficult diagnosis to manage. I saw patients with this problem when I worked in dialysis in the 1980s, and when they would relax and start to drift off to sleep, their movements were so jerky and uncontrollable that they just kind of jolted themselves back into wakefulness. The DSM-5-TR criteria says that the symptoms have to be at least 3 days a week for at least 3 months, and they consist of neurological sensory motor things such as uncomfortable sensation in the lower legs, a burning, tingling, crawling, itching feeling, and this uncontrollable desire to move those legs, and relief comes with moving them. It starts when the person is at rest, like when they're starting to relax in the evening or when they're trying to sleep. The clinical presentation is they may state that it's difficult getting to go to sleep and staying asleep. They may complain of excessive daytime sleepiness, impaired functioning. Their bed partners might complain, and there's usually a family history of restless legs. Differentials include pain, arthritis, any kind of peripheral neuropathy that also causes tingling and burning and itching, peripheral vascular disease, ischemia in the lower extremities, numbness, radiculopathy from low back issues, but also depression, anxiety, panic disorder, PTSD, and there is something called secondary restless leg syndrome that comes from iron deficiency and from pregnancy. Management for restless legs includes sending them for a sleep study, reinforcing sleep hygiene, encouraging relaxation through whirlpool, massage, and exercise. Some medications have been used for restless legs. Some of them have the unfortunate side effect of augmenting the problem, instead of making it better. But these are some of them. Dopamine agonists and Mirapex, you may have heard of that one, and Requip or Requip XL.